Hey guys, I always like to start these off by saying thank you. I know it's 8 o'clock here, and depending on where you are, you guys had a long clinical day. And I'm a parent too. I say I might have a table full of toys right in front of me in our kitchen table. It's a hot mess. So I like that there's a blur function in the back. But I just want to say thank you just for being on it. I know I usually when I'm on these webinars or doing a webinar, I have an earbud in and I'm either putting my kids down or doing tubby time or things like that. So just thank y'all. And then we have a great team that's with us today. I met Isabella previously, so I don't have your picture yet. I have to see. I usually have everyone's pictures on here, but today we're going to talk about bioceramics and pediatric dentistry. This is something I do a lot of, these little baby tooth core buildups. And what I mean by that is, and we'll kind of talk about hemostasis, pulp and medicaments, what to cover these up with. But I usually kind of bend over backwards to save some of these broken down teeth that are fairly vital. And then I'll use a bioceramic NeoPUTTY and clean up those margins and then place a high viscosity glass ionomer cement or something over there before I place my zirconia crowns or stainless steel crowns as well. Just a disclosure, NuSmile kind of gives me some cool stuff to play around with and provides a little bit support for this as well. So I just like to put that out there. I use everything that I'm talking about, and I use it day in and day out in hospital dentistry and also in private practice. So nothing I'm talking about today is everything that I use is what I'm talking about. So just thank you to the NuSmile team. What I really like about NuSmile is that they really want you to be successful with their products. They really want these to work in your hands. And if you're ever having issues, whether it's the NuSmile tech team with Jordan and Chris with the SOAN or the scanner or just everyone else at NuSmile. So just make sure to reach out to your friends at NuSmile and some of these cool people. I've known some of these people for a really long time. I've known Zoe for a really long time. I've known Jordan for a really long time. I've known Preston for a really long time. So just making sure that you guys are really making this feel like a community and that you're trying to get your questions answered. So this is me. I have two wonderful kids, Winston and Carolina. You might hear them next door. I work at Cincinnati Children's Hospital. I did my residency there, and then I wanted to go do something wild. So I did the National Health Service Corps, paid back 4 years. I worked in Sohotsa Medical Center in Navajo Nation, and then I worked at the Eastern Branch Cherokee, just west of Asheville, North Carolina. And this is my awesome wife, Magdalena, who I always like to thank her too. She is wrangling my two kids right now. You guys probably can't hear it, but I can. So she is very supportive in allowing me to do these things. I don't take that for granted. She's a general dentist and works just as hard as I do. These are my two wild dogs, Waffles and Maple Syrup, two wonderful French bulldogs that cause a lot of trouble in our house. So this is Cincinnati Children's Hospital. It's right in Cincinnati in the tri-state area. Our dental clinic is a teeny tiny part of this giant hospital system. We're just kind of right here. It's a beautiful clinic. Here are some of my wonderful colleagues. Some of you guys might know them: Bobby Thickershe, John Chu, Scott Schwartz, Elizabeth Gosnell, Juwong, and Amory Matuzak. We have some new friends: Alexis Liu. That's my wife, Magdalena, Shrey Danuka, Jenna Panic. So it's just a really cool group of us. I have a goofy Instagram / YouTube channel that I started for the residents. During COVID, I was trying to find different ways to teach the residents. And one of the residents was like, "Can you just make a YouTube video?" So I don't make money. I don't know how to be an influencer. I don't think I could influence anyone to do anything, but I post cases on there. Some of them are interesting. It's just a fun outlet to post cool pictures of some cases that I do. This is the office that I work at. I'm there tomorrow. This is my wonderful boss, Dr. Marie Callan. If any of you guys know her, she's an amazing woman. She's been in practice of pediatric dentistry for a really long time, and she worked full-time faculty at Cincinnati Children's for a while too. So she's been a great mentor in my career and journey as well. And so I always like to talk about the thing I really like about NuSmile is jumping on these webinars. I've listened to so many of these, whether it's the SOAN or whether it's Matt's lectures on zirconia crowns or some of these new team members that are coming in and doing some of these lectures. And they're really helpful and they're really interesting. Sometimes, even though I've heard them a bunch, I'll just pop my earbuds in and listen to them. So I think everyone's here tonight for a reason, and everyone's trying to challenge themselves and understand more things. I tell the residents, don't get out and do nothing. do what I just taught you. I hope you're teaching me something 5 or 10 years from now, because that's how pediatric dentists should be, especially now in this time where we have these intraoral scanners and intraosseous anesthesia devices and better biomaterials and better restorative materials. It's just wild what's available to us. So NuSmile started with Diane Kruger and just with our pre-veneered crown. And it's really wild to see how that NuSmile has kind of turned into a pediatric dental solutions company. I always say NuSmile is like the Brasseler of pediatric dentistry. They are providing you with your restorative biomaterials and, soon like intraoral scanning and anesthesia devices as well. So, and preventative. So it's kind of cool to see what's going on at NuSmile and how they've evolved from a crown company to almost like a pediatric solutions company. Pretty rad. So here's an overview. All of these are recorded, and I always encourage everyone to just go on. I've listened to Joshua and Ann's talk on YouTube sometimes when I just want a refresher for the SOAN or things like that. I try to listen to the latest one before I teach the residents or before I teach. Sometimes I'll teach some of the local ones as well, some similar courses. So try to go on and check that out. They're all recorded. It's a great resource. But tonight we're going to talk about bioceramic materials and how they're utilized in pediatric dentistry. And part of that is talking about the inflammatory process, right? Because these materials, whether it's like PureWood MTA or Biodentine or NeoPUTTY or NeoMTA2, there's chemical properties that reflect the inflammatory process of a reversible pulpitis and dentinogenesis and how that's made in tertiary dentin. So we're going to talk about that and how those materials, the products in them, help influence that tertiary dentin formation. So we're going to be thinking about MTA or bioceramics and how the pulpal response is actually an inflammatory response of the immune system. Then we're going to talk about some clinical uses in these as well. So just kind of the things that we're going to go over that I just discussed. Okay, so let's kind of dive right into it. MTA-based liners and pulp therapies. So what's the difference here? An MTA modified liner, that's going to be your NeoLiner product. So that is a resin-based product that has a ditricalcium silicate. So it's only used for indirect pulp capping. The pulp hates resin. So you're not going to want to use this in any instance of exposed pulp. So indirect pulp capping. Think about any time, what I like to tell dentists is anytime you would have pulled out Vitribond, you're going to pull this out instead. Your MTA putties, like NeoPUTTY, NeoMTA2, NeoMTA Plus, that's going to be for your vital pulp therapies, regenerative pulp procedures. Apexification, direct pulp capping, apexogenesis. And we're actually just going to talk about Vineet and Jim Cole's study that just came out in your last AAPD article. And it's pretty cool. So Jim Cole and Vineet Deer from Maryland have been doing this case series on pulp therapy, vital pulp therapies, non-vital pulp therapies. And they just in the last 2 AAPD have published permanent pulp therapies and recommendations. So they've done a really good job with those. They're great articles if you haven't read them yet. Why am I interested in this stuff? I always joke that when I finished residency, it was a very tangential era where we didn't really have MTA. We weren't really using zirconia crowns. SDF just came out and we didn't scan anything. I did not touch a scanner until way later in my career because we didn't do that in dental school. And I'm sure a lot of you guys didn't. Now all the residents, I'm like, who's scanned? And like, that's all we do, you ding dong. So so you almost have to back teach these things. And when I came back to residency to teach, I'm like, man, no one's doing pulpotomies anymore. So I just did a retrospective evaluation and saw that, wow, and right around 2015 at our program, the percentage of procedures from indirect pulp therapy to pulpotomy totally flip-flopped. And that downslide that you're seeing from 2019 to 2020 is from COVID. In another 10 years, I think it'd be interesting to take a look at this again. But that's what kind of got me interested in this. So when we're diving into, this is again, those previous articles that I talked about from Jim Cole and Vineet out in the University of Maryland, they came out with these flow charts. And over the years, people used to say, okay, we would have formicrosol, MTA, and ferric sulfate. When I was in residency, ferric sulfate was the hot, sexy girl that everyone wanted to use. Former creosol was still back there, and then ferric sulfate went away when some of those kids had those facial swellings because of the colony forming units in the water was mixing with the iron loving bacteria. So now, really, if you look at the most current literature, di-tricalcium silicates like MTA, biodentine, NeoPUTTY, those are all in the same world of di-tricalcium silicates. And then now, former creosol is a secondary recommendation, and ferric sulfate, ZOE, sodium hypochlorite are now tertiary recommendations for vital pulp therapies. So it's pretty interesting. And we've all kind of looked at this, and we're going to look at some clinical cases too, as far as our ICDOS or our ADA caries recommendations of infected dentin, affected dentin, and how that zone from the carious lesion as it progresses down to the pulp and how the pulp addresses this. So is inflammation a prerequisite for pulpal healing? Yes, it is. And that kind of blows your mind, right? This is an inflammatory process. It's an immunological process. So what happens is you actually have some local friends, some local cops or police officers that are directly positioned at that area where the pulp meets the DEJ, some local odontoblasts that can cause tertiary dentin formation in areas of deeper influxes. So like pulp exposure, severe caries, deeper cells or fibroblasts are recruited up through the root into the pulpal spaces and actually morpho-differentiate into odontoblastic-like cells. And some of those things that we're going to see in our pulpal medicaments help that become successful. And we'll point those out too. Okay, so we're going to kind of nerd out and do some dental school stuff for a second and say some Harry Potter spell words, when we say dentinogenesis imperfecta, things like that. So you have pulpal response to a mild stimuli or a more intense stimuli, reactive dentinogenesis or reparative dentinogenesis. So when we think about those preps that we would have traditionally just put Vitrabond on because we didn't want the tooth to be sensitive, or we felt like we were relatively close to the pulp, but wanted to insulate that area that we were going to etch over. And then we have that, I think about that as our reactive dentinogenesis, where those local odontoblastic cells can place reparative dentin. Now let's think about our deeper areas of caries or pulp exposures. Maybe we have a direct pulp exposure. Maybe we have trauma that exposed the pulp, or maybe we just have caries into the pulp that requires a pulpotomy. So that is our reparative dentin, where cells and those stem cells are recruited through an inflammatory mediated process and to differentiate into odontoblastic-like cells. Cool. So our reactionary dentin is very similar in structure to dentin. It's well organized. It looks, smells, it tastes like dentin. So this is in a response to a mild stimulus. Reparative dentin is when those cells are more massively affected by trauma, an invasive carious lesion, or something noxious. So those mesenchymal cells are recruited from the deeper layers of the pulp tissue, and then they morphodifferentiate into odontoblastic-like cells. So this isn't as organized. It's a little messy looking. And I do a lot of apexogenesis in my brain's not working, and revascularization. It's kind of similar what happens at the root apex of the tooth with the shed stem cells or the Hertwig's epithelial root sheets. And I'll share a case like that at the end. And just like how we learned about the caries imbalance in dental school from John Featherstone, I don't know if his first name's John, I apologize, Dr. Featherstone. But there's also, I call this the inflammatory imbalance or the pulp imbalance. So as infection or bacteria progresses down our dentinal tubules, these local regenerative cells try to combat that by layering reparative dentin down in these cytokines and chemokine receptors, just like when we learned and we took immunology, are increasing the immune response to help recruit those dentinal stem cells to change into odontoblasts. Pretty cool. So what I like to show here is that this really is an immunological response. Kind of mind-blowing. These are all of the biomarkers in cells and things that are involved in an irreversible pulpitis. Dendritic cells, neutrophils, macrophages, cytokines. I mean, this is kind of mind-blowing. This is a little microcosm of an immune response, but within inside the pulp of the tooth. So now let's think about how what we're selecting as those pulpal materials help influence that reactive or reparative dentin. So this is just a really good article that I like to use as a sounding board for a discussion. So some of our things that we used to use, some of you guys still might use Limelight or DiCal. These are our calcium hydroxide based products. I will argue that you could just throw those away and switch to a di or tricalcium silicate product. And and we'll talk about the reason why. But calcium hydroxide really cannot compare to the performance of an MTA-like product. So you have DiCal, which is, I remember in dental school, it was like DiCal Vitribon. And that is our calcium hydroxide mixed product that eventually washes out or forms little tunnels over time. And then Limelight is kind of like the calcium hydroxide version of Neoliner. It has resin in it. So again, anything that has resin in it, you can't use it next to the pulp. Now we have our bioceramic based or di and tricalcium silicate products. So this is going to be like your biodentines, your NeoPUTTY. Now this article came out, I believe, in 2021 or 2022. So there wasn't a lot of publications on NeoPUTTY and some of these other putty-like products. But what I like to say, if you look at the more recent publications, NeoPUTTY is pretty much nuts and bolts similar to biodentine. And I know, and try not to think about these things as like Coke, Pepsi. They're all di and tricalcium silicate. So MTA, biodentine, MTA Angelus, they're all in the same family of hydrated calcium silicates, but there's different proprietary things that make them kind of work. But they're all very similar as far as the main ingredient is a tricalcium silicate powder. And then there's other things that have resin in there. So Theracal LC is going to live in the same family as like Neoliner. All right, so when we think about our properties, what I'm going to talk about is our pH value and change. How alkaline does that product get? And when you look at some of our calcium hydroxide products, so DiCal has some level of alkalinity that stays pretty alkaline. But then you look at MTA Angelus or your pure di and tricalcium silicates, so NeoPUTTY is going to fit in here as well, where it actually has a more basic or alkaline property. And a lot of times those pure products of the di and tricalcium silicates actually continue that alkalinity for a lot longer. And you look at something like Limelight, well, that's not giving you anything from a pH value change. So if you're using this product in the hopes that you're going to be really stimulating calcium formation in tertiary dentin, it's just not going to be really happening as much as something as Neoliner, which is kind of living in this world right here. Excuse me. And then we want to look at water sorption and solubility. So calcium hydroxide famously leaves these little tunnels because it doesn't adhere to the floors of your preparation as readily. So you want a product that doesn't wash out, but is also going to have some type of water sorption. And we'll talk about that and why that's important, because the byproduct of some of these di and tricalcium silicates is still calcium hydroxide. And then we're also going to talk about why cumulative calcium release is important. And you're going to notice in some of your pure products, like biodentine and MGA Angelus, and then this is going to be your NeoPUTTYs and NeoMTA, that they're going to have a higher degree release of calcium and why that's important. And then once you add resin to this, so this is also going to be true with Neoliner. Anytime you add resin to it, that calcium release goes down a little bit. And then we're going to look at why it's important that Neoliner actually has a pretty high degree of calcium release relative to Theracal LC. Excuse me. Oh, so calcium ion release, again, if you're using a product like Limelight, you're not really getting anything. That little panda bear is sitting all the way down here. Your pure products, so some things that aren't diluted with resin, are going to have your higher degree release of calcium. And then once you add resin to it, that kind of goes down. I kind of make this, if you think about like a high viscosity glass ionomer, like Equia Forte, or something that doesn't have resin in it, that's going to have your higher fluoride release. And then once I add resin to it, like Fuji 2LC, that goes down, and then resin doesn't have any. So it's kind of analogous to that if you want to kind of think. Excuse me. Okay, so we're going to kind of thread this needle as all those things that I just talked about. Well, why is that important from a clinical aspect? So we look at the AAPD diagnosis from primary permanent teeth for indirect pulp therapy and then the baseliner. And I think these are very similar as far as how they're utilized clinically. So that's why I kind of lump them together. An indirect pulp cap and a protective liner our goal is we're trying to cover the pulp from being exposed. Now, whether we're leaving caries or not, I'm not taking a histological sample of that tooth to see if there's bacteria in there. So I think that's, indirect pulp cap in my mind is anything that I'm using to prevent a pulp exposure, whether I'm leaving caries or not. And then what is a degree of bioactivity? When we look at the actual definition from the ISO for bioactivity, it is just a medicament that causes the in vivo formation of calcium phosphate hydroxyapatite-like layer. So something that I am putting on the tooth that is going to stimulate hydroxyapatite formation. That is our kind of baseline definition of bioactivity. Okay, so I know that was a lot of like loops that were, so now we're going to try to tie all that together. So let's think about that article and those definitions of what do we actually need for a bioactive material. So remember we talked about the degree of calcium release. Well, calcium ions actually enhance that pulpal cell proliferation and differentiation. So that's essential for that hard tissue formation when we're trying to get our reparative regenerative dentin. And the degree of calcium release is dose dependent. So I'm going to want something with a relatively high amount of calcium release. So our NeoPUTTYs and our pyridine tricalcium silicates. But if we're also using a resin in there, then we want to look at the degree of calcium release in areas where we're not exposing the pulp. And then also the alkalinity of that material, one, contributes to the antimicrobial effect. So if it has a stable pH, so remember how we looked at that limelight, and because it's calcium hydroxide, the pH level wasn't significantly high. So if we want to use a product that's light polymerizable in a baseline or an indirect situation, I want something that has a relatively high degree of alkalinity to have the antibacterial effect. And that high alkalinity also helps stimulate tissue growth factors and again enhances the tertiary dentin. So the degree of calcium release is important, and also the alkalinity for the antibacterial properties and stimulating tissue growth factors or other factors that enhance our tertiary dentin. So when we think about our physical properties, so remember that slide on water absorption, we want something that should not fully dissolve in water faster than its ability to provide reparative dentin. So when you think about calcium hydroxide, it would get these little tunnels because it doesn't form well to the floor, and it's just not giving you what you need. But we do want it to have some level of water absorption because it's part of the chemical reaction that we'll talk about later for the release of the calcium hydroxide byproduct. But we don't want to have it lead to voids under the restoration. All right, so this is, again, we're threading these needles. Calcium hydroxide or MTA. So again, calcium hydroxide is insufficient to adhere to dental walls. That's why I said if you guys are using Limelight, you can go trash. I don't need this anymore. And then try to look for a di and tricalcium silicate product. And same thing if you guys were still using dical or anything similar to that. And our biocompatibility of MTA is far superior because of its calcium ion release, its alkalinity, and also it's actually less cytotoxic than calcium hydroxide as well. And MTA and its application has a direct effect on the regeneration potential of those dentinal pulp cells when we talked about tissue growth factors. Cool. And then, so those little tissue growth factors from the pulp cell actually help direct that deeper cell migration. So remember things like that deeper level of insults like pulp exposure and things like that help morpho differentiate those cells that are recruited and they stimulate into odontoblastic-like cells. So our material selection really does affect the outcomes of that immune inflammatory response of our reactionary or repetitive dentin. Cool. And we kind of talked about the protective liner and what our objectives are. Again, this is a very blurred line when you look at like indirect pulp therapy. And the objectives and the goals and the outcomes are the same, right? I don't want to expose the pulp. I have an asymptomatic tooth with either a reversible pulpitis or a tooth that is either asymptomatic, and we're either leaving the deepest layer of decay, or we're really just trying to not expose the pulp or not actually etch over that pulp layer as well. So let's look at our products that we can use for this. And one thing I wanted to talk about with NeoLiner that comes up and that people ask on IPETA or other things. So NeoLiner is our di and tricalcium silicate. So it's an MTA-based product that has resin in it. We're not using that for direct pulp exposures. These are indirect or baseline modalities. Now in the IFUs of the product, it says use of a bonding agent prior to placement of neoliner is recommended. When I talk to the people and how they got this through the FDA or things like that, that just goes because it has resin in it. But you should not be etching and bonding prior to your neoliner placement, even though it's in the IFU. I don't actually think NeoSmile can change the IFU of this product because of how it was approved. You're using less than a millimeter thickness. So what you're really getting is the micromechanical retention from your prep design in the smear layer as that neoliner adheres to that small amount. And I'll show you guys clinical photos as well. As far as if we're just trying to do an indirect or utilizing a base liner over areas where we think the pulp could be next to it. And then we're going to light polymerize that, etch, bond, restore over it. So again, kind of talking about some of these other products, if you look at some of the studies, and I'll show one, TheraCal LC says you can use it for direct pulp capping, but again, the pulp does not like resin. And when you look at those nuts and bolts studies, TheraCal LC always causes a higher level of cytotoxicity because it is a resin-based product. And then Limelight is our calcium hydroxide product, and we already talked about why we really shouldn't be using that anymore. So we use neoliner. I use it all the time. I think it's a great product, and we'll kind of talk about its clinical utilization. Another thing that I like about it, and this is comparing to TheraCal LC, is that it has, and this is internal, but it does have a higher degree of flexural strength, compressive strength, and a degree of calcium release. When we're thinking about incorporating this product into our restorations, you do want something that has a similar degree of flexural strength and compressive strength relative to the resin composite or other material restoratively that we're putting on top of it. And then we talked about why the degree of calcium release is important for these products as well, as far as our overall clinical roles of reactionary or reparative dentin. So this is just a study too that looked at some of these products that have resin in them. They should not be used in direct pulp capping medicaments. They found that TheraCal is toxic to pulpal fibroblasts. Well, anything with resin in it is going to be toxic to pulpal fibroblasts because of the decreased potentiality for bioactive potential from those products. The pulp does not like polymerized or unpolymerized resin. So only use these in indirect pulp capping situations. So neoliner is nice. It's easy to place. We can command cure it. If you guys mix your Vitribond or some similar product and you're trying to use your DiCal instrument and place it right in those things, this I use a sealant tip and it does a really good job just going exactly where you want it to go. And it has a continuous high release of calcium. It has a alkaline material that is going to promote our hydroxyapatite formation, and that alkaline pH actually has a bactericidal effect, which is what we want if we're doing an indirect pulp therapy. It's insoluble, moisture tolerant, and it helps protect against hypersensitivity. One, because it's releasing calcium, but two, we're not etching and putting our bonding agent directly over these areas. So here's just a nice clinical case of a cuspid. If we make out that deeper area of maybe some reactionary or reparative dentin has already happened, well, I just put a really small amount of neoliner, and I love it because it's so easy to place on primary teeth. And then you etch, bond, restore, and polish over that as well. So it's really easy to use in your restorative solutions. Here's another case where we're removing this amalgam. And here's our caries that's removed, remove the amalgam. And then what my goal for this is I'm placing a thin layer of neoliner, less than a millimeter, over the floor of this restoration where I think the pulp could be. If we go back to the x-ray, I really want to avoid etching over this high pulp horn area. I want to put a nice layer of this neoliner down, and then I'm going to etch, bond, restore over that material, whether you're using a selective etch, total etch, or no etch technique, depending on what bonding agent you're using. And you can just restore right over this. Here's another clinical case. I feel like when I see these on x-rays, my tush gets really tight. And this is never on like the best, it's always on a kid that's like super nervous. I feel like that's how all of these, they haven't been in a few years. You do their exam, you take their x-rays, and you're like, oh man. And so we removed our decay, and here's our partial caries removal. So we still have this this infected versus affected dentin. And then we are gonna leave, again, indirect pulp therapy, this leathery affected dentin, but we have 360-degree clear margins around this tooth. And we place less than a millimeter layer of neoliner. We isolate, etch, bond, restore over this. It's just so easy to use. This is a case of band stabilization. I got to give a shout out to my boy Paul Bond. Happy late birthday, Paul. I don't know if you're listening. But Paul kind of has, I guess I've also heard this, the Paul Meadow technique. I call it the Paul Bond band. And there's a dental code for this too, where we cement or place a smooth band. So that is going to act as my restorative matrix. And then we remove this MH, this hypoplastic, hypomineralized or molar hypomineralized affected teeth structure down to this more leathery affected dentin. And then we place our neoliner just over that area where we could be worried that that pulp could be exposed. And since we already have that orthodontic band, that's going to act as our matrix band, and we're just going to restore directly over that, or we'll fill part of that up with the glass ionomer, high viscosity glass ionomer, prepare some of the back and laminate it over with a composite for better wear resistance. And now there's even better bulk fill composites. I know like Stella from SDI or some of these other products that are chemical cure composites that you could just fill that whole area up. So you're not etching, but they do use that adhesive primer on top of it as well. This is from Dr. Matt Lucier. I just think it's a great example. I love these for permanent anterior teeth, where you're just trying to put some neoliner or some type of medicament either in the mesial or distal proximal box. This is just so easy to use because it has that sealant tip. I don't even push it out. I'll just push it to where it starts to come out of the tip, and then I'll dab my medicament in those areas with the syringe tip. I don't even push it out, and then I'll light polymerize it, and then you just etch, bond, restore right over it. And this is another case from Dr. Lucera where it shows the radio opacity, probably a little bit too much neoliner, and he does talk about that too when he's talking about this. It's again, the IFU is just less than a millimeter, and it does come out a little quick. If you feel like it's coming out too fast, use a smaller tip. If you need to cover a wider area like those permanent teeth, then use a larger gauge tip. So you can have different gauges if you want to, if you would like to control the flow of this medicament. And now we're going to kind of move on to vital pulp therapy, but just neoliner, again, you don't have to bond before you place it. It is in the IFUs, but it's really more because of how they got this product through when they were getting approval for it. You don't actually need to bond to it. It's going to sit there. It's not going to go anywhere. I promise you, unless you put way too much of it on there. So now we're talking about our vital pulp therapy. So our indications. So these are times where the pulp has been exposed, whether it's a mechanical or carious exposure, and we have vital pulp tissue. So these are all of our AAPD guidelines for vital pulp therapy. We can get adequate hemostasis just with a cotton pellet. We have absence of spontaneous pain. There isn't sort of apical or furcal radiolucencies that would kind of indicate us as irreversible pulpitis or necrotic tooth. We don't have any presence of necrosis. Cool. All right, so what is a hydraulic calcium silicate? So these, again, when you use the word MTA or biodentine or things like that, all you're really talking about are di and tricalcium silicates. So this is a hydraulic calcium cement that water is the reaction medium. So that's why if you're using a putty-based product, I always tell people to use a slightly moist cotton pellet. And because water actually is the medicament or is the reactionary medium that this occurs in. So our byproduct is a calcium silicate hydrate and then calcium hydroxide. And that is similar in both di and tricalcium silicates. So that's something to think about when you're using your putties or some of these other products, is you can take a slightly damp cotton pellet and put that medicament in as well. So here's just kind of a quick little video showing that. So this is me taking out the cotton pellet. And I think, I can't remember if I edited this down. Okay, yeah, so what I'm trying to show here, I didn't really fully take out the pulp tissue, but how much bleeding is too much bleeding. as that thing's coming up from the mesial pulp horn and also from the palatal area as well. And I don't think I took out all the pulpal tissue here, so I'm going to go back and use slow speed excavation um, to remove some of those large pulpal spaces. And I'm usually using like a 4 or 2. If I'm really down into the spaces, I'll use a 2 slow speed. And then we're gonna this is just moist cotton pellets. And then I like to use this dispensing guide when you're utilizing the NeoPutty. It just helps you. This comes in every kit of NeoPutty. You can wipe it down after your use. It just really helps your staff be good stewards of whether you're using a mix or or the NeoPutty itself. I used to use the NeoMTA, and I had one staff member mix like an entire Lincoln log of this stuff. So I and always put it back into that metal container. It just and have make sure your staff is recapping it. It just helps keep it fresh and not set up because it's a moisture-based medicament. So when you look at this now, we have little pools of heme at the bottom, and that's totally fine. And we're going to use that increment that you just saw in the video. Even that's probably a little bit too much, to be honest with you. And you just really need a millimeter, millimeter and a half to cover that area. And then I'm taking a moist cotton pellet, coming back in with a dry cotton pellet just to condense some of that medicament down. And then I'm placing either Vitrabond or Fujito LC or Equia Forte or Ionoseal. That Voco product is really nice. So any bulk fill like material you can place to fill those areas up. And then that's our final prep design as well. And I already kind of talked about the dispensing guide. And then one of my favorite things for NeoPutty is just rolling it on the back of your glove. Sometimes when I'm teaching people like, oh, I hate delivering it. If you just take it, roll it on the back of your hand, or have your staff member rolling on the back of the glove, you can pick that thing up with a cotton forceps. It's so easy to manipulate and handle and deliver into the orifice of the tooth. Again, what are our uses for this? Any area where the pulp has been exposed. This is kind of my workflow for a stainless steel crown. Again, I usually build all of my stainless steel crowns back up with either a double pump of Vitrabond or Ionoseal by Voco or Fujito LC or GC Equia 4K. It just depends on where I'm working and what. So again, how much bleeding is too much bleeding? I try to make videos of heme just so we can look at this together. This was a tooth that we ended up doing the pulpectomy on. So you're going to see me suction this, and that blood's just going to go bloop, right back up. And I like this tooth because it looks like it's making a smiley face at you. But look at that heme just pouring right into that tooth. And then this was after like 5 minutes or a few minutes of placing cotton pellets. So if the blood is just filling up like that into the orifice, that means there's too much inflammation in the apical spaces. So the periapical inflammation has progressed enough. So now we need to either do a pulpectomy, or if you don't do pulpectomies, think about your extraction and placement of the distal shoe, or a band loop if the 6-year molar, if the other tooth has erupted in the space. What is an example of good bleeding? Something like this. You do need some moisture because, again, this is a moisture activated medicament. So I wouldn't try to get perfect little no bleeding stumps. But it's important to not have active heme because that's what's giving us an indication on how well we have that pulpal controlled. And if you're not seeing that too, just going off your symptomology from the patient. This is another video if you guys care to watch it. I'm trying to keep an eye on time to allow for about 10 or 5 minutes of questions, but this is just a similar idea of areas that have been affected by space loss and how I built this up. I'll show just the point where we have good hemostasis, because I think it's important to see a bunch of different videos of what the pulp looks like. If you're just switching to this material, if you use ferric sulfate or formicreosol, you have to really be more attuned to how the pulp is responding just to cotton pellets. Not you don't want to use any hemostatic agent inside the pulp as well. And another thing I like to tell people is if you're building this back up, try to leave those margins clear of your medicament, whether you're using, this is GC Equia Forte, because that you want that medicament to try to adhere to that exposed tooth structure of your margin. And I just kind of pat this down with a moist cotton pledget. I think I don't always use a T-band. I think I just did that for the video just to show. But a lot of times I just ploop it in there. But that's kind of after my prep. And I just like that it reestablishes the retention and resistance form of your stainless steel crown or zirconium crown. I love these in permanent teeth. This was a young friend who had just a carious pulp exposure, and we did a partial pulpotomy. And then this is a follow-up. Tooth is asymptomatic. You know, if we ever have to go back in and do a little bit more, I don't know if this is just not the best X-ray because it looks like we got the caries out, but I think we have since seen this patient back and still asymptomatic as well. But it allows you to do these pulpotomies and maintain the vitality of these molars. And what's really cool is the continued apexogenesis of these molars. This was a friend that the parent just did not want this tooth out. Because some people go say, well, can't you just do extraction and substitution of that area? Well, you know, after we talked to the parent, they really just didn't want it out. So I said, well, let's try this. We did a pulpotomy on this. And what's really wild is you can see the continued apexogenesis of this tooth. And then I use a lot of, when you're doing these on permanent teeth, I would advise that you get a surgical length, slow speed round burr. So it's called a right angled surgical length burr. And you get about 5 in a pack. And I think they come pre-sterilized. So if you're worried about going into a permanent tooth, I wouldn't take caries out with it. But once you get into the pulp and you're doing the pulpotomy, I like to use those burrs. And here's just a nice workflow for a deeper carious lesion where we took out as much of the decay, left this affected dentin, sodium hypochlorite pellet after we isolated, NeoPUTTY. Now, could you have used NeoLiner in this? Absolutely. I think I was just nervous that I could have had a micro pulp exposure, so I still get a little itchy if I think I'm really close to the pulp. I probably wasn't in hindsight. I was probably just kind of being a wuss. And then there's our final restoration as well. And then here's that orthodontic band. This is from Dr. Paul Bond. But again, it allows for that continued apexogenesis of that tooth. This is from, again, the most recent publication from Jim Cole and Vineet Dar. And this is their nice workflow for pulp. And what they did is they're looking at all of these publications and studies, and then they're finding these teeth with either extremely deep caries or deep caries with radiographically distinct dentin barrier that you are recommending, so strong recommendation for our direct pulp cap, partial pulpotomy, or full pulpotomy. And the question is, well, when do you differentiate from that? And then again, this is in these areas where the deep caries that has radiographically distinct dentin barrier. In extremely deep caries where radiographically extending into the pulp, regardless of pain or symptoms, we're kind of ending up at this full pulpotomy area if our bleeding can be controlled. So just kind of interesting. And we'll show 2 different cases. This is again from Dr. Matt Lucero, where you can see he did an amazing job removing all of the caries and just had this teeny, tiny pinpoint pulp exposure that is most likely a mechanical exposure. And on the X-ray, I think what I like to say is I can still make out this pulp area. So I think a lot of the caries that we're seeing is actually this larger area right here. And then he did a partial pulpotomy where bleeding was very well controlled, put his NeoPUTTY NeoLiner over that, and then just restored. And this patient was asymptomatic. And I actually did this case today, a totally different case, where we had a special friend that was having large recurrent caries on the tooth. And we had a pinpoint pulp exposure. Well, if you look, this is not the same as Dr. Lucero's beautiful cleaned out tooth. There's still a lot of schmutz in here, and this was still really soft with my spoon explorer. So when do you differentiate needing to do a partial pulpotomy, a full pulpotomy, a direct pulp cap? It really has to do in an asymptomatic patient, in my mind, with how close that caries approximates that pulpal tissue in relation to where that inflammatory process is occurring. So we actually decided, because of the amount of leathery dentin left with a pulp exposure, to continue, and the fact that this was a special friend and they might not be able to tell us, or I apologize, being as definitive as possible in this situation. If this was a patient that was fully cooperative and I can go back in and do a different type of endodontic procedure. So we continued with the full pulpotomy and stainless steel crown coverage over this. So I think when you look at this publication and the strong recommendation for these, it really depends on the marriage of clinical symptoms, the clinical presentation which you find yourself. And I also think the patient's ability to relate that symptomology to you and how much caries and the carious burden of this tooth as well. This is a trauma case where I love showing this case because this was a re-trauma of a tooth we already did a pulpotomy on, and you can see the tertiary dentinal bridge information. And this tooth was still vital, so we just did another pulpotomy on it and filled this up with GC Equia Forte. You can actually appreciate the tertiary dentin bridging here. And then we just did another pulpotomy, and these are our restorations over that. I'm running out a little bit of a time, but I do a lot of aesthetic fragment reattachment as well. And I just think it's a nice way to, this is where I love using my Neo liner because it's so thin and I can so easily place it that I can reattach these fragments easily. And if I'm really close to the pulp, I love being able to use the NeoPUTTY and then reattaching these fragments as well. I think it's a nice way in this patients who have developing dentition or deeper bites where that lingual of the bulky strip crown would have me just have to take so much of that away that I can, or teeth that just don't look like strip crowns. And I'm maintaining the anatomy of those teeth and the aesthetic presentation of that as well. And I also do a lot of endodontics. Again, the difference between regenerative endodontic procedures, apexification, our revascularization is when we have this open apex and we can do a regenerative endodontic procedure once the root is more fully formed, but maybe not quite that stage 4, in between stage 3 and stage 4, is when we would use NeoPUTTY as an apical plug. So this was a case where, again, we did aesthetic fragment reattachment. Young man had trauma, ended up with a periapical passosis, a periapical pathology from that. And we decided to do regenerative endodontic procedure. We entered the tooth. Sometimes these can be a little bit wonky because the canal is so large getting your working length. So a lot of times I'll do working length films and then kind of estimate. I'm a little short here, so I would increase it to that area as well. And then we bring our friend back after we put a medicament in there. If it's necrotic, it's a 2-stage procedure. And then when we come back, we induce bleeding with the headstrom file. I actually use a rotary file to induce bleeding. And then we let it sit there for quite a few minutes until you get a little bit of clotting. And then we use a collagen matrix and condense it down into the tooth that acts as a scaffold matrix for these regenerative. So you're not actually regenerating the nerve, but you're regenerating the pulpal complex inside of the tooth. And then we place a MTA barrier, and then this is GC Equia Forte. So here is probably our collagen matrix, NeoPUTTY. And I didn't get it down enough. I usually like to try to get it below the CEJ from the aesthetic standpoint as light passes through. And then here is our GC Equia Forte, and then I usually put a composite on the back of it as well. So this is the patient at follow-up. I think we're like 6-month follow-up. Now, not the best hygiene right here. I have a little bit of plaque, but you can see the soft tissue looks super healthy. And what's really rad is you can see the continued apexogenesis of that, and that's what you want to see as your clinical success. If we go look back at this film, this little panda bear is wide open. So we have that continued apexogenesis of that tooth, and the patient remains asymptomatic. Now, if this were to become symptomatic again, you would just have to go through this area and consider whether you're going to now do a pexification with calcium hydroxide or an MTA barrier, or try regenerative endodontics again. And then this is my little dog's waffle and maple syrup. And I always like to tell this story because it's kind of silly to end with, is that we had a little pulp exposure on maple and the vet wanted to do a root canal. And I was like, no. I was like, well, we're going to bring him to the house. We're going to clean it with sodium hydrochloride. We're going to do a direct pulp cap, cover it with GC Equia Forte. And then I just kept recovering and covering as a little bandage until that pulp kind of healed itself. And that tooth is still there. Not the cleanest tooth in the world, but it's asymptomatic and it's doing well. And I went like 5 minutes over. I apologize. But thank you for everybody's time. This is my contact information. Email me, ask me any questions. I want you guys to use this. I want you to be successful with it. I want, if you're transitioning your office to using a calcium silicate material, I want you guys to be able to use it and have success with it as well. So thank you for your all's time. I really appreciate it.
Yeah, great job, Patrick. Thank you so much. So we're going to do some Q&A here, everybody. If you could please stick around and ask your questions in the Q&A function. First one, not a question, but woohoo, Cincy 08, Dr.
There you
Callan.
go. Who is it?
uh, Dr. Carla Stappenbeck,
All
Dr.
right,
Callan,
Carla.
and Dr. Matasek. Hope I'm saying that right.
Yeah, we have a Cincy Instagram. The residents post a bunch of cool stuff on there. So everyone out for those Cincinnati people, everyone's like, "Oh, do you remember Dr. Steiner?" Or I was like, "Oh, those guys were long gone before I was here." But Rick Campbell, I got to hang out with him. Steve Wilson was there when I got there. Murray Dock. So for you Cincy crew, everyone says hello.
That's awesome. And then first question is for neoliner after you put it, uh, will you etch and bond or will you etch and bond before?
Oh yeah, great. So again, this is where it gives a lot of confusion in the IFU. And Jordan, I don't know if you can speak to this or we can get a little more information on why. From my understanding, is this is just how it had to go through to get approved. So you
Yes.
do not etch and bond prior to putting the neoliner on, even though it says it in the IFU. Please just put half a less than a millimeter layer, etch bond restore on top of that.
Yeah, that's
Um,
exactly right.
Yeah, so you're gonna do that after you place your neoliner, just like you would do if you were. This is analogous to how you would use Vitrabond or DiCal. Place that medicament down, etch bond, restore on top of it.
And then for the next question, we have in trauma cases, when you do pulp cap with NeoPutty, um, what would you put over NeoPutty? GI, neoliner, composite resin? Does neoliner bond to
Good
NeoPutty?
question. Anything really. I know that sounds crazy. So usually I'll put neoliner on top of it, because I try not to leave it bulky, and I felt like if I'm putting GI or Vitrabond, it tends to be a little bulkier. So I'll literally just put my NeoPutty where it needs to go. Now, if it's a lot of medicament, like I have, like you guys saw in that one case, that was GC Equia Forte. If it's just like a pinpoint pulp exposure or pulpal blushing and you don't feel comfortable putting resin on top of that, I call up my this is my like makeup videos that my wife. I take a little bit of NeoPutty and I take my micro brush and I'm like dab 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 like a blender brush, and then I'll put neoliner on top of it because that keeps it really thin, and that lets me put my restorative material, whether I'm doing a buildup or something, on top of that as well.
Yeah, great answer. Thank you, Patrick.
Mhm.
Um, well, that's the last of the questions for right now. Let's oh, just got one in. Awesome. For pulpotomies, after NeoPutty, do you recommend using Timpet?
Yeah, you can. So there's this really cool study that looked at medicaments placed over dying tricalcium silicates, because these products seal so well. You can put anything over it. You can put Tempet. You can put, which is a Centrix product for those of you who have never used it. I think it's a calcium. It's a calcium based calcium sulfate, calcium plus something product that it's a non-eugenol based product that is moisture activated. Yeah, you wouldn't want to put Tempet directly on exposed pulp, but you can put anything over NeoPutty. You can use GI, you can use Tempet, you can use IRM. The only thing is, if you're using a eugenol based product like IRM and you're cementing your crown with a cement that's an RMGI, just be mindful of that, because of the resin isn't going to do as well. But you can put anything over NeoPutty, as long as you have that good seal. I usually use IonoSeal, Vitrabond, Fuji 2LC, but yeah, we use Tempet a lot. I've used that as well. I just don't use it as much anymore because I try to thin down how many products I have, even though I just said a bajillion, but it's just depending on where I'm working. But it works well. You can put Centrix Tempet over it.
For the next question, what is activated when light cured? Resin you mentioned is contraindicated next to pulp and IPC procedures.
Oh, you said what happens, or say that
Yeah.
again, Jordan?
What is activated when light cured? Resin you mentioned is contraindicated next to pulp and
Oh,
IPC.
okay. Yeah. So the question is, the way I'm understanding it is, when you're using a resin-based product so you can use any resin-based products in indirect pulp. What we were talking about is, so when you look at these research articles, it's not when you light polymerize it. It is the resin monomer, whether that's HEMA, which is, remember, a hydrophilic resin monomer, or BIS GMA or TEGMA or UDMA. Any of these resin monomers that might not be fully bound to these tissues that can be cytotoxic. So it's when these resin monomers are in direct contact with pulpal cells, whether it's a micro exposure or direct exposure, it is that cytotoxicity from the resin monomer that causes that. It's not the light polymerization. Now you can, when you look at these, when you look at the IFUs for Activa, which is a second generation RMGI, it actually says to not use the Velo lights that have the high cure potentiality, because it's like when you use those 4-second quick cures, it's like you're trying to cook something on broil. It's like you're baking a cake on broil. You are just cranking up how much light is and wavelength is being emitted. You could potentially cause thermal pulpal cytotoxicity as well. So just make sure you're looking at the IFUs for the product and if it correlates to those light curing. But usually in cytotoxic events, it's due to the resin monomer itself, not necessarily the light polymerization.
And could you clarify as well, like with resin products being safe to use for indirect as opposed to?
Yeah, no, great question. Yeah, so your Neo liner or any product that has resin in it that is indicated for indirect, that's okay. Where you want to avoid using these products are direct pulp capping. Anything where the pulp or vital pulp tissue is exposed, you do not want to put Neo liner or anything that has resin in it on the pulp.
Right, but NeoPutty is specifically indicated for direct.
Yep. So NeoPUTTY is again, it's a pure uncut. It's the good stuff. You can go right on vital pulp tissues.
Perfect. Another question here. After pulpotomies, if I tried the crown before, can I just cement it on top of NeoPutty, or do I really need to build it up?
Oh no, that's just something weird that I do. Sorry, I should preface that. And I have a great picture that I didn't include in this. If that crown ever comes off, so to answer your question, yeah, you can cement your crown directly over it. The reason why I do this is no matter what cement you use, over time, the cement's what's going to rinse out first, not the restorative material. So if I build that up, I know that that's well sealed. So if that crown were to come off, and I have a case where the crown did dislodge, and you bet my buildup was still there. But no, you don't have to do that. Yeah, you can totally just cement. Again, you can put anything over NeoPUTTY. You can just cement your crown directly on top of it with whatever cement of choice you would like. High viscosity, Keytac, Fuji One, any cement, RMGI cement.
Perfect. Did you say there's a code for an orthodontic band used with an include?
Oh yeah. Let me. It's called. Yeah, great question. It's called band stabilization. I'm gonna look it up for you. It's called band stabilization per tooth. Dental code D2976. D2976. Band stabilization per tooth. So anytime we do those buildups where we band stabilize, we charge that code. If I'm doing a more definitive restoration, then I also include the restorative code as well. So if I feel like I'm doing the pulpotomy, band stabilization, I'm putting a restoration on top of that, and I'm considering that a definitive restoration, then I'm also including the band stabilization code as well as the restorative code and the pulpotomy or indirect pulp therapy, depending on what you're doing.
Dr. Premise, good to see you on.
What?
Yeah,
Cool,
here's a question here. So
what about cool.
What about Theracal PT? Is it also cytotoxic?
So yeah, Theracal PT came out, and that was or is there's studies on Theracal PT, and I'm going to make sure I'm talking. Let me look it up because I know what product you're talking about that it has resin in it. When you look at the nuts and bolts comparison studies of Theracal PT compared to these other products, there is a layer of cytotoxicity to it. So like you're not going to get the biggest bang for your buck with that product as well. And I am familiar with it, and I've kicked around with it a little bit. I didn't like the results I was getting, but when you look at some of the studies for that, and it does have resin in there, I would say your success rate is probably not going to be as high as if you were just using a pure di-tricalcium silicate. So if you were to do a nuts and bolts study between Biodentine, NeoPUTTY, Ceraputty, and Theracal, TheraCal PT, your success rate's probably going to be lower with the TheraCal PT than it is going to be with those uncut products. And I can, if you want to send me your email, I could find some studies for you because I know I've read a few of those because I was interested in this when it first came out, but I just don't think I'm sold on it. So if you want to send your email to Jordan, I could try to find some stuff and send it to you.
Yeah,
And
certainly.
I use pulp dent products. I'm not poo-pooing them. They make some really nice products. So I actually really like Active. I think it's a cool restorative material. So
Cool. What's best way to place NeoPutty and instrument used? Sometimes when I place that, I notice it moves around a little bit.
So I use it, if you go back and I can just whoever that asked that, I can share you this presentation. I just roll it on the back of my glove and I take pickups and I put it in the chamber and I take a moist cotton pellet, not drenched, just moist, and I just dab it down in there. You could also just use a micro brush. Yeah, don't use a metal instrument, don't use a ball burnisher, don't use a condenser. Just take a moist cotton pellet or use a like a good micro brush, dab, 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 and it'll just go where you want it to go. This I don't know why, but I just roll it on like a pizza dough. If you ever made pizza, that's going to solve all your problems. It won't stick to it, and you just put it in there with pickups.
Perfect. I feel like we've got this one a couple times, but does Neoliner bond to NeoPutty in the same
Oh,
way
that's actually a really good question.
in the same way GI bonds to
Yeah,
NeoPutty?
so when you think about it, no, Neoliner isn't. You're not really when you put something over NeoPutty, you're not really bonding to it. You're just putting. You're almost getting either micromechanical retention. Same thing if you put Vitrabond over NeoPutty or any other product. You're just kind of laminating over it, just like you would have done with your DiCal and your Vitrabond, your base liner. So you're just getting a little bit of micromechanical retention, which is why I try not to use a ton of it, right? Try to just place it exactly where it needs to go when you're in those Vitrabond neoliner or NeoPutty neoliner situations. And I think about those like anterior trauma where there's like a little bit of blushing on maybe one of those pulp horns, and then you're covering it up with a little bit of NeoPutty and then putting something else on top of it. But no, that's a great question. It won't bond to it. It's they still work individually, but you can layer over it and cover it is a better way to put it. I just think of like again for those older people like me that graduated in the DiCal Vitrabond days, it's very similar to that as far as you're just a baseliner.
Perfect. A couple of people want to say thank you. Very relevant information,
Oh, hey,
Dr.
appreciate you. Thank
Tyrone
you guys.
Rodriguez. Awesome. And then looks like last question here. Is the core buildup reimbursed?
No, this is something stupid I do. It's not. Yeah, I wish you could. Um, if no, because like post core crown code, if you're doing it, no, probably not. I mean, you could look at it in permanent. You could sell me if you're doing it on a permanent tooth. Yeah, absolutely. Like if I'm doing like number 19 pulpotomy and I need to fill that chamber with something and then put a stainless steel crown over it, yeah, probably, but not on primary teeth. That's just something silly that I do. But I don't see how that's any different than my endodontist doing a root canal on 30 and then me filling it and putting the stainless steel crown on it. What's the difference? You know what I mean? As long as you document it really well and why you did it, um, I I mean, how is that any different than filling the chamber up with glass? So even when I get root canal back from my endodontist, I do the same thing. I take out the temporary or the cavit, I clean it, fill it up with GC Equia Forte, and then put my restoration on top of it. So but in a primary tooth, yeah, I wouldn't do that. You might get in trouble on that one. But a permanent tooth, I think if you documented it really well with your rationale for care, yeah, I don't see why not. And as long as it's in the explanation of benefits and why you're doing it, it's no different than you doing it after a root canal, in my opinion. I would do
Um,
it to sorry, one more caveat. I would do that too once you know that the tooth is that you're good, that you're out of the woods with that pulp therapy. Or if you do it and the tooth becomes symptomatic, I would take what you charge the patient and build it in to the restorative procedure that you're going to utilize, whether you're going root canal or it just needs to come out. I would roll it into that.
Perfect. And then are you finding that indirect pulp caps are being covered for primary teeth with restos
Ooh,
or SSCs?
it depends. It depends on the insurance. For Medicaid, like we're at the hospital, we're like 83% Medicaid, so no, we don't get reimbursed for those. So it just depends. I know that's not the answer you want to hear, but it depends on the insurance if you're getting reimbursed for that or not. I would say for our Medicaids, no. Some of the private insurances, if it's covered or not, it just depends. But probably not. But we still bill it out because you never know. Sometimes we'll get reimbursed. Depends on the provider. Globally, probably not.
And that's it for the questions. Dr. Premise said, great talk. Thanks so much. And
Hey, thanks for being
uh,
on.
Dr. Carpio said, great presentation. As an endo-pedo dentist, I truly enjoyed it.
Yeah, cool. That is my. I have a ton of endo cases. That is my miscalling, I think. So good for you. We do a ton of endo. I have a whole thing on root canals and apexogenesis and stuff that I do. Um, that's my second life. I would have been an endo pedo, but
Awesome. Well, Patrick, thank you so much. Thank you everyone else for joining us tonight. Thank you, Zoe. Thank you, Isabella. But Dr. Ruck, thank you again so much.